My goal today is to speak about the glenoid tract instability management score and to explain what is, how to apply. When we have a traumatic recurrent shoulder instability, we have, of course, soft tissue lesion, the very famous, very well-known Bankart lesion. But we have to keep in mind that there are in more than 80% of our patients with recurrent dislocation, bony lesion, the heel sacs on the humeral head and on the glenoid. Very often, those are bipolar. It seems that those patients with recurrent instability, they have soft tissue lesion and they have a heel sacs lesion and glenoid bone loss. We call this bipolar bone loss. So we have a Bankart lesion that is a soft tissue. And when we speak about the lesion of the bone on humeral head, we speak about heel sacs lesion, and it is very important to look at the position of the heel sacs. The blue zone is the glenoid tract. That is the part of the humeral head that guarantees the bone stability. The glenoid tract is medial to the footprint and is 83% of the glenoid width. If, like in this case, the heel sacs, the red line, is within the glenoid tract, is stable from the bone point of view, and we call this lesion on track. We feel comfortable to fix through the arthroscopic Bankart repair. But this is very important. Look at the position of the heel sacs. If we have an heel sacs that is medially translated, and there is a complete disruption of the medial glenoid tract, we have an heel sacs lesion that is defined off track. The off track lesion leads to a very unstable shoulder from the bony point of view. In this case, we advise for a bone reconstruction most of the time through a Latarjet. The glenoid tract concept is very important because if you keep in mind that the glenoid tract is 83% of the glenoid width, and if you have a glenoid bone loss, you have a smaller glenoid tract. The smaller is the glenoid tract, the more possibility you have that the heel sacs is off track. So the concept is very important because give you the possibility to detect bipolar lesion, heel sacs and glenoid bone loss that can be off track if the heel sacs is medial or if there is an important glenoid bone loss, or on the other side, if they are on track, it means more stable from the bone point of view. The big dilemma when we treat this kind of patient is when to do a soft tissue repair. We can speak about Bankart repair, remplissage, versus a bone block reconstruction. The classic, of course, is the Latarjet. The first research is Pascal Ballot. He pointed the attention on the bone. And he stated that according to the HESI score, there are parameters, there are risk factors very, very important. Is the age, degree of sport, type of sport, and shoulder hyperlaxity. Those lead to 2 point, 2 point, 1 point, 1 point. And then he gave an evaluation of the presence of the heel sacs in external rotation and the loss of contour on AP view. If you have this positive, you have 2 points for the heel sacs and 2 points for the loss of the bone on the glenoid. Pascal suggested if you have more than 6 points, there is a contraindication to the arthroscopic Bankart repair. There are other researchers that stated that the key point is not 6, but is 4. So if you have patients that have 1, 2, 3, 4 points, you feel comfortable to perform arthroscopic Bankart repair. But if you get a number of risk factor is a score that is more than 4, you should perform an Latarjet procedure. According to the on-track off-track lesion, we prefer to evaluate the glenoid bone loss and the bone loss on the heel sacs on according to the on-track, off-track concept. So we maintain the same non-bone parameters: age at surgery, degree of sport, type of sport, shoulder hyperlaxity, with the same point. But instead of making a measure to the X-ray, we look at the interplay between the Hill-Sachs lesion and the glenoid bone loss. So if you have a stable bony lesion on track, 0 point. If you have unstable bony lesion off track, you have 4 points. So there is a contraindication to the Bankart repair. This is the difference. So if you have 1, 2, 3 points in a GTM score, there is a contraindication to perform a Latarjet, and we prefer to perform arthroscopic Bankart repair. If you have 4, 5, 6, 7, our advice is to perform a Latarjet procedure. If you follow the GTM score, we have to keep in mind that EASY score predicts twofold increasing recommended Latarjet versus GTM scoring criteria. It means that if you follow the EASY score instead of the GTM score, you perform more Latarjet, because it's enough that you have an Hill-Sachs on the X-ray or and loss of contour on the AP, and you have to perform probably a Latarjet because you have 2 points more. It's different according to our score, because in our score we evaluate the interplay between the glenoid bone loss and the Hill-Sachs. So you have more possibility to perform arthroscopic Bankart repair. And it's very interesting that the mean patient outcome scores were marginally worse for those patients, exactly 33 in our paper, that for the EASY score should be treated with Latarjet, and for the GTM score with arthroscopic Bankart repair. Probably there is an explanation about this, and you have to remember the subcritical glenoid bone loss and the peripheral Hill-Sachs lesion. There is a critical point. When you have glenoid bone loss that is more 25%, there is a contraindication to arthroscopic Bankart repair. And also the position of the Hill-Sachs lesion on the glenoid tract is very important. The more medial is the Hill-Sachs, the more possibility you have that is off track. But according to Yamamoto paper, also if it is the Hill-Sachs on track but is very medial, we call this peripheral, and if we treat this patient with arthroscopic Bankart repair, we have WOSI score that are around 300, 400. They are enough good, but not so excellent. So you have to keep in mind to give a look to the position, even if the Sachs is on track, if is peripheral or if it's central. So in conclusion, if you have a patient that is on track, that are the most of the patient, arthroscopic Bankart repair is indicated. If you have a patient that is on track, you have to pay attention to the glenoid bone loss. If the glenoid bone loss is less than 25%, you have to give a look if it's toward 0 or toward 25. There is a huge difference. So we are speaking about patients that are on track. If they have glenoid bone loss that is between 0 and 13.5%, there is an indication, of course, for arthroscopic Bankart repair. But in those patients that are on track, but the glenoid tract is between 13% and 25%, there is a relative contraindication to arthroscopic Bankart repair. Probably because if you perform arthroscopic Bankart repair, you are going to repair the ligament on the glenoid bone loss. And so you could have some stiffness in the shoulder, especially in abduction and external rotation. So it's open the discussion in these patients. You can choose a Latarjet versus an open capsular shift. Very important is the message that you have to give a look to the position of the Hill-Sachs, especially the position in medial lateral direction. The more medial is the Hill-Sachs, the more possibility you have that is off track, or that you can guess the worst WOSI even if it's on track, according to Yamamoto paper. Another category are those patients that are on track and have a glenoid tract that is more than 25%. In this patient, usually there is a classic indication to the Latarjet technique. Interesting is the group where patients are off track and the glenoid bone loss is less than 25. You have to try to understand if they are off track because the heel sacs is medial. If the culprit is the heel sacs or glenoid bone loss, is an open discussion, or if is off track because the glenoid bone loss is the culprit, so the indication is easy. In case one, where the culprit is the heel sacs lesion, is off track because the heel sacs lesion, remplissage and bunker repair is the main indication. In case two, where it is not clear who is the culprit, we can discuss. In case three, where the culprit is the glenoid bone loss, of course, our advice is to make a reconstruction of the glenoid platform through the Latarjet technique. In conclusion, we agree that the glenoid tract is very important, but keep in mind that the more medial is the heel sacs, the more we'll engage. So give a look to the position. The more is the true glenoid bone loss, the more the heel sacs will engage. The more lax or the more strain is in the ligament, the smaller is the glenoid tract. And the more the shoulder is at the end range of motion, the smaller is once again the glenoid tract. And always keep in mind that very often those patients suffer from a scapulothoracic dyskinesia. So there is an altered movement of the scapula, and this could lead a change of the glenoid tract once again. So we think that, of course, the glenoid tract is an intelligent concept, but of course, we have to improve in the measure of the glenoid tract. I mean the interplay between glenoid bone loss and the heel sacs that is the key point in bone stability. Thank you very much for your attention.